rivaroxaban and apixaban. In rivaroxaban, the lower dose of 15 milligram was received by only 1,400 patients, and in apixaban, the lower dose of 2.5 milligram was received by only around 400 patients. So we have a very strong data with both the doses of dabigatran, but with rivaroxaban and apixaban, the data is quite strong with the full dose, but the data is not very strong with the reduced doses. Now, if you look at the different stroke and systemic embolism risk with the different drugs in comparison to warfarin, you will find an apixaban was superior to warfarin in prevention stroke and systemic embolism. Dabigatran 110 milligram and rivaroxaban, there was a trend of being better, but then they were not statistically significant. If you look at the ischemic stroke, just at the ischemic stroke part of it, only dabigatran 150 milligram was beneficial as compared to warfarin, with a significant reduction of stroke by about 24%. And because of this reason, patients who have recurrent ischemic strokes, dabigatran 150 milligram twice a day is still the most preferred drug. You can see here a 24% risk reduction with dabigatran 150 milligram twice a day. Dabigatran 110, rivaroxaban and apixaban, as you can see, they are not significant reduction. Now, if you come to the major bleeding, the bleeding milligram twice a day dose or apixaban as compared to warfarin. So a patient who has a higher bleeding tendency, if you look at the bleeding risk of dabigatran 150 twice a day and rivaroxaban, it was similar to that of warfarin. The intracranial bleed, good thing about the NOACs, all the NOACs actually reduce the intracranial bleeding, and all were significant. There was significant reduction with all. And the maximum reduction we find is with dabigatran 110 milligram twice a day and apixaban 2.5 or 5 milligram, with almost 60 to 70% reduction of intracranial bleeding. So when there is a risk of intracranial bleeding, you should actually go for the lower dose of dabigatran and apixaban. And this is the major benefit, because all other bleedings are easily treatable, and problem comes with intracranial bleeding, which has a very dreaded complication and prognosis. And that is the reason we actually prefer NOACs over warfarin. So now, post-hoc analysis of the RELY trial, subset of patients who received appropriate dose according to age and bleeding risk. Because in this trial, it was later discovered that many of these patients did not receive the actual optimal drug doses. So if you look at the different risk of major bleeding, the major bleeding was actually reduced with 110 milligram as compared to warfarin, but the bleeding risk was similar between dabigatran 150 and warfarin. Intracranial hemorrhage, both dabigatran 110 and 150 milligrams significantly reduced the intracranial bleed. So more importantly, the intracranial bleed, which has a worse prognosis, was significantly reduced. Stroke and systemic embolism was significantly reduced only by the 150 milligram dose, a 35% reduction. Ischemic stroke was again reduced only by dabigatran 150 milligram twice a day with a 24% reduction. Cardiovascular mortality, there was the trend towards reduced mortality with both the doses, but then they did not reach statistically significant. Now, if you look at the entire RELY population, many patients receive 150 milligram. Among these 150 milligram, some patients should actually have received 110 milligram, and actually they were over-treated. Similarly, in patients who received 110 milligram, many patients should have received 150 milligram, so they were actually under-treated. So you should take only those patients who received the recommended dose of 110 or 150 milligram. And then if you compare with warfarin, how does the results look like? Now, how the recommendations came, dabigatran 110 milligram is recommended for patients more than 80 years or who have a Hasbled score of more than equal to 3 or who are on verapamil. Dabigatran 105 is recommended for everyone less than 80 years, the Hasbled score of less than 3. So if you can see here, if dabigatran was given in the optimal dose, and then if you had compared with warfarin, the major bleeding, life-threatening bleeding, and intracranial hemorrhage all were significantly reduced with dabigatran as compared to warfarin. So there is every reason to use dabigatran to reduce the bleeding risk, and specifically the intracranial bleeding risk as compared to warfarin. And if you look at the efficacy endpoints of reduction of stroke, systemic embolism, and cardiovascular mortality, all were reduced by the appropriate dose of dabigatran as compared to warfarin. Now, this is a study actually where prospective analysis of 3 Danish health registries between August 2011 and November 2015. The data was analyzed. New users of dabigatran, apixaban, and rivaroxaban as warfarin. More than 61,000 patients were actually studied, and only patients on standard NOAC doses were included. Limitations was that it was an intention to treat analysis, and the follow-up duration was limited, and patients included prior to availability of apixaban. So as you can see here, this was published in the BMJ, and dabigatran and apixaban had the lowest bleeding risk as compared to rivaroxaban and warfarin. And this is exactly the same results that we have seen in the earlier phase 3 trials of these drugs. If you look at the mortality, dabigatran and apixaban were the 2 drugs which actually significantly reduced the mortality, and there was no reduction of cardiovascular mortality with rivaroxaban or warfarin. So here is the chart. As you can see, apixaban and dabigatran, the curves were actual overlapping, and rivaroxaban and warfarin, again the curves were exactly overlapping for any bleeding risk or all-cause mortality. So patients initiating treatment with dabigatran or apixaban experienced a significantly lower risk of bleeding or death than those initiating treatment with warfarin or rivaroxaban. Now, if you look at the different trials with dabigatran, the phase 3 trials, almost 50-50 patients received the higher dose and the lower dose. And the real world, it was again similar. But if you look at rivaroxaban, 79% patients actually received the full dose, whereas in the real world, only 60% patients received the full dose. Similarly, if you look at apixaban, 95% patients received the full dose of 5 milligram twice a day, whereas in the real world, only 64% patients actually received the full dose of 5 milligram twice a day. So in real world, actually, large number of patients are actually receiving the lower dose, which has not been adequately studied for both rivaroxaban and apixaban, and we do not actually know how much benefit these patients who are using the lower dose are getting. Again, this is the Danish registry, which I suggested earlier. And if you look at the results of this registry, ischemic stroke and systemic embolism, there was a non-significant reduction with dabigatran 110 or rivaroxaban 15 or apixaban 2.5. As you can see, death was actually higher with the lower dose of rivaroxaban and apixaban, but it was neutral with dabigatran. So that clearly shows that the lower dose of rivaroxaban and apixaban may not be as effective or as safe as we think about it. If you look at the bleeding risk was lower with 110 milligram twice a day with dabigatran as compared to warfarin, but then it was neutral with a lower reduced dose of rivaroxaban and apixaban. So that tactically means that you are not reducing the bleeding risk. You are not reducing the ischemic risk when you are using a lower dose of rivaroxaban and apixaban. Rather, there may be a slightly higher risk of death. So dabigatran 100 milligram twice a day showed reduced bleeding and similar mortality versus warfarin in a Danish population. We do not know whether this can be actually translated with the same in our population also, but we should be careful about these drugs when you are using the lower dose. Now, coming to the doses in renally impaired patients, it is very important because large number of our patients are elderly, have multiple diabetes and hypertension, and there is some amount of renal impairment. So you need to calculate the EGFR. And it is very simple to remember that if the EGFR is more than 50, then no doses adjustment is needed for any of the NOACs. And all the NOACs are actually not recommended if the EGFR is less than 15. If the EGFR is between 15 and 30, one should not use dabigatran, but the others could be used with caution. If the EGFR is between 30 and 50, you can use apixaban safely, but all the other three NOACs you should use with caution. So this is the way you remember, and accordingly you need to adjust the dose or give the proper NOAC to a particular patient. So what is the ideal dose? If the age is between less than 80, then dabigatran 150 milligram twice a day should be given. And if the age is more than, for rivaroxaban, there is no dose that is the EGFR is less than 50, then you actually should give the lower dose. For apixaban, again, no dose adjustment is needed for majority of the patients. Only if the patient has two of the three, that is age more than 80, body weight less than 60, or a creatinine of more than 1.5 milligram per deciliter. If a patient has any two of these three, you should give the lower dose of 2.5 milligram twice daily. Now, as you can see here, there are drug interactions with the NOACs. The way to remember is that basically you need to remember that there could be some drug interaction with amiodarone, diltiazem. You may actually have to reduce the dose by about 50%. Coming to when to stop a NOAC before a surgical intervention. Again, as we know, kidneys. So if you take a tablet of dabigatran, if there is renal impairment, the action will persist for a longer time. And that may not be true for other drugs like apixaban and rivaroxaban. So basically, when you should stop the drug is very, again, simple to remember. For apixaban and rivaroxaban, you should stop it 24 hours before the operation if it is a low-risk operation, and 48 hours before an operation if it is a high-risk operation. For dabigatran, again, if the EGFR is more than 80, it is same 24 and 48 hours. 24 hours for a low-risk operation and 48 hours for a high-risk operation. But if it is between 50, EGFR is between 50 and 80, then you multiply it by 1.5. So it becomes 36 hours for a low risk. And if the EGFR is between 30 and 50, you multiply by 2. So that means it is 48 hours for a low risk procedure and 96 hours for a high risk procedure. If the EGFR is less than 30, then actually we do not use dabigatran. But for the other drugs like apixaban and rivaroxaban, you have to multiply by 1.5 times. After the surgery, if the surgery was, if surgery we had immediate and complete hemostasia, there was a clean lumbar puncture, you can resume it 6 to 8 hours after surgery, or else you should start it 24 hours after surgery. If the procedures are associated with immobilization, initiated a reticular heparin 6 to 8 hours after surgery. If hemostasis is achieved, NOACs are started 2 to 3 days after surgery. Thank you very much.
Thank you, sir. It's a really wonderful presentation by Dr. Gushrai. And sir,
you have to look what is the main problem. If the patient is having frequent frequent embolic events, then I think dabigatran is the preferred drug in majority of the patients. Of course, if the renal function is impaired, then we again think twice before giving dabigatran. We may think of other drugs also. But dabigatran can also be given with dose adjustment. Bleeding risk is actually very high. Then we actually many times prefer apixaban, and we may actually also go for a low dose of dabigatran. So these are the only two drugs where we know that the bleeding risk is actually low as compared to other drugs. If you look at cardiovascular mortality reduction becomes the most important thing, then again you should actually go for apixaban, or you may also go for dabigatran lower doses. So you have to decide about what is the main problem. Major decisions are taken on the basis of actually 3-4 points. One is what is the risk of this embolic events, what is the bleeding risk, what is the renal function, and what is the cardiovascular mortality likely to be.
Thank you, sir. Thanks for addressing the questions.